Thank you for giving me the opportunity to present our retrospective study about the patient with fecal incontinence. No disclosure. Obstructive defecation syndromes include aspects of abnormal evacuation symptoms such as straining, incomplete emptying, and repetitive toilet visits. ODS primarily develop via maladaptive pelvic floor coordination during defecation. Anatomical abnormalities such as pelvic floor descent and rectocoeles can coexist and being primary and secondary to this. In terms of patient management, conservative approach should be the first line management, while surgery might indicated only when all conservative management has been failed and there are anatomical defects. The aim of the study was to review our cohort of patients presenting with obstructive defecation syndrome and establish predictor of success for ODS treatment. Initial assessment for patients with ODS is important to direct them to conservative treatment only or a combination between conservative and surgical treatment. Predictors of success are particularly important because they can avoid unnecessary treatment to patients and redirect resources to a group of more favorable people. Telephone triage assessment is well known in our institution, so from development symptoms, referral, telephone triage, from triage, diagnostic test, MDM, and biofeedback. TAC referrals to telephone triage assessment clinic include different validated questionnaires such as ICQB, St. Mark's Continence Score. Patient characteristics. So we analyzed 545 patients referred to our third referral center with main symptoms of ODS between 2013 and 2017. 471 females and 74 males. And based on the results from the last appointment, we have classified patients in two groups, the group who improved and the group who didn't improve. Several predicting factors have been analyzed to understand if we can stratify patients during the initial assessment. Demographic, these are all the characteristics, so the age, so we have seen that the age was significant, so people a little bit older, they had a more favorable outcome, and people that they had a baseline worse quality of life had a worse outcome. Diagnostic test, so we did abdominal ultrasound, anorectal physiology, and defecatory proctography in approximately 2/3 of the patients. Anorectal physiology ultrasound, as you can see, there are none of the results has reached statistical significance, and abdominal ultrasound as well. Diagnostic test, we can conclude that none of the results from the test have resulted to be significant in predicting patient outcomes. So in this case, do pelvic floor investigation need to be performed as part of the initial assessment? Treatment. 485 patients had conservative treatment with a median section of 4.28 and a length of follow-up of over a year. 51, 9.4% have surgery only when conservative management failed. Conservative treatment include different kind of technique. In reality, none of them has been result predictor of success for conservative treatment. Interpretation of the result. So despite our extensive statistical analysis, we have found that only advanced age and less compromised quality of life in the ICQB are predictor of success for improvement. In reality, the results obtained from the test, as well as the presence or the absence of anatomical abnormalities or anatomical physiology, haven't been found to get any prognostic value in our cohort of patients. In conclusion, we can say that based on this finding and the fact that the pelvic floor tests are invasive and expensive procedure, we should reserve them for patients not improving first-line treatment. Pelvic floor tests are not predictive of success for treatment and should be reserved to patients who has failed first-line treatment in the view to offer surgery if anatomical abnormalities are present. Predictors of success should be identified to predict outcome for patients with difficult defecation.